Welcome to Rheumatology Virtual Grand Rounds. I'm Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology here at the Cleveland Clinic. And it is a great pleasure to introduce my colleague and good friend, Carol Langford. Carol is the Harold Schott Chair of Rheumatic and Immunologic Disease and the Director of the Center for Vasculitis Care and Research here at the Cleveland Clinic. I wanted to incorporate a topic that really outlines the best practices for treating patients with small vessel vasculitis, and I couldn't think of a better person to do this than Carol. So welcome.
So welcome everyone to Rheumatology Virtual Grand Rounds. In today's session, we'll be focusing on the best practice for initiating therapy for small vessel vasculitis. Today's disclosures include that the discussion of therapeutic products today, there is only one licensed product for the treatment of any form of vasculitis, so any other form of treatment discussed constitutes unlabeled use of the product. The objectives of today's session include to describe the appropriate baseline investigations for small vessel vasculitis patients, to critically appraise the evidence for using ANCA for diagnosis and monitoring, and to analyze the pros and cons of different initial therapeutic strategies. In framing today's discussion, it's important to recognize the definition of vasculitis, which is broad and really refers to inflammation of the blood vessel. When this occurs, blood vessel damage can ensue, either as a result of compromise of the vessel lumen resulting in organ ischemia, or potentially from thinning and attenuation of the vessel wall leading to aneurysm formation, or to breach of the vessel wall with hemorrhage into the surrounding tissue. Because of this, vasculitis is not one specific disease, and blood vessel inflammation can be seen in a variety of settings. Vasculitis can occur secondary to an underlying disease or exposure, as can be seen in the setting of medications, infections, malignancies, transplantation, cryoglobulinemia, or in a range of underlying rheumatic diseases. On the other hand, there are forms of primary vasculitis that are unique disease entities that are as yet without an identified underlying cause, and where vasculitis forms the pathological basis of tissue injury. An important question comes is how do different forms of primary vasculitis differ? There may be different features in terms of epidemiology, such as age, gender, ethnicity, or frequency. Different forms of vasculitis may be characterized by different clinical manifestations and patterns of organ involvement. This may in turn affect the methods of diagnosis, which can include biopsy, arteriography, or a combination of clinical features and laboratory abnormalities. And this in turn also influences the decisions regarding treatment and outcome that can range anywhere from forms of vasculitis that may be monitored with supportive care to forms where the immediate initiation of aggressive immunosuppression is critical in order to save organ and life. And finally, forms of vasculitis can often be grouped in terms of the predominant size of vessel that's affected. So if we look at the vascular tree ranging from the aorta all the way through the capillaries and through the veins, different forms of vasculitis may have a predominant vascular bed that's affected. This can include large vessel vasculitides, as we can see from this enlargement of the aortic root in a patient with Takaysu arteritis, medium vessel vasculitides, as we can see with this arteriogram, and digital infarction as occurring in a patient with polyarteritis nodosa, and then in a range of small vessel vasculitides, which here is exemplified by these ground glass infiltrates with alveolar hemorrhage in a patient with microscopic polyangiitis. So when we think about our primary vasculitic diseases, although there is no absolute with terms of what vessels are affected, these are often grouped according to their predominant size. Large vessel vasculitides, such as giant cell arteritis and Takayasu's arteritis, medium vessel diseases, such as polyarteritis nodosa, Kawasaki disease, predominantly of children, and primary angiitis of the CNS, and then the broadest group, which would be the small vessel vasculitides, which include a diverse number of diseases. Today's case will focus on the entity of granulomatosis with polyangiitis Wegener's, but as we can see that this is not the only small vessel vasculitic disease that can occur. So with that, let's turn to our case. An ENT colleague asked you to see a 55-year-old male he is concerned may have granulomatosis with polyangiitis Wegener's. He has otherwise been healthy with a past history notable only for hypolipidemia, for which he takes atorvastatin 20 milligrams daily. 3 months ago, he started noting nasal congestion and epistaxis. He went to the ENT physician, and despite antibiotics, nasal care, and antihistamines, his symptoms worsened. 2 weeks ago, he began feeling unwell with anorexia and a 10-pound weight loss. He noted arthralgias that jumped from joint to joint, each time lasting about 24 to 48 hours. He also describes the appearance of painless bumps on his bilateral elbows. He denies headache, vision or hearing changes, shortness of breath, cough, chest or abdominal pain, weakness, or numbness. On physical examination, his vital signs include a temperature of 37.1, blood pressure of 135/75, respirations of 12, and a pulse of 98. His skin reveals verrucous papular lesions on the bilateral elbows. The nasal exam reveals mucosa that, per both your exam and your ENT colleague's notes, appears bloody and has a cobblestoned and ulcerated appearance. The eyes reveal no redness and have normal ocular movements. The ears reveal normal tympanic membranes. Chest is clear. Cardiovascular exam is a regular rate and rhythm without gallops, rubs, murmurs, and pulses are 2/2 throughout. The abdomen is soft, non-tender, without hepatosplenomegaly or masses, and the neurological examination is normal. So which of the following investigations would you recommend be performed to evaluate for a possible diagnosis of granulomatosis with polyangiitis Wegener's? You should choose all of the applicable options. A, serum creatinine. B, urinalysis. C, computed tomography of the chest. D, antineutrophil cytoplasmic antibodies, or ANCA, or E, antinuclear antibodies, or ANA. So as we focus on this case, it's important to understand a little bit about the nature of granulomatosis with polyangiitis Wegener's. This is an entity that many of you may know formally as Wegener's granulomatosis. This is an uncommon disease that's estimated to affect about 3 in 100,000 people. It occurs equally between men and women, and the mean age of onset ranges between 40s and 60s, although this can occur at any age. In terms of etiology, there has been no currently identified infectious or environmental trigger or genetic association, although investigations remained active into all of these possible associations. However, there has been strong evidence that the disease is immunologically mediated. This comes from data gathered within the laboratory, the responsiveness that we see to immunosuppressive treatment, and evidence of inflammation seen on tissue histology. And indeed, histology is one of the 2 key characteristics by which this diagnosis is known, in which we see evidence of necrotizing granulomatous inflammation and vasculitis affecting the small to medium-sized vessel. This is seen in combination with a clinical predilection to involve the upper airways, lungs, and kidneys. In focusing more on these clinical features, we can see that upper airways involvement occurs in upwards of 95% of these patients. This is something we can appreciate in the office by inspection of the nasal mucosa, which often reveals an ulcerated, bloody, or cobblestoned appearance. We can also see by computed tomography evidence of sinus mucosal thickening, which can involve, as seen here, the maxillary, sphenoid, and ethmoid sinuses. In some instances, this mucosal inflammation can lead to loss of blood supply to the cartilaginous portion of the nasal septum, leading to its collapse, as seen in this saddle nose change in this patient. The second most common site of disease are the lungs, and pulmonary involvement occurs in about 85% of these patients. Just about any radiographic pattern can be seen. The most common, as is seen here, is that of bilateral nodular infiltrates, but one can also see multiple thin-walled cavities, single thick-walled cavities, or ground glass infiltrates, which pose the most immediate threat in representing alveolar hemorrhage, which can be immediately life-threatening. The third most common site of disease are the kidneys, and 80% of patients will have glomerulonephritis at some point during their disease course. Often confounding the diagnostic assessment is that only about 20% will have active renal disease at the time that they present to medical attention. This is concerning because it can be rapidly progressive, it is typically asymptomatic, and is detected by our vigilance to examine the urine sediment for evidence of proteinuria and features of activity such as dysmorphic red blood cells, and is seen here, the red cell cast. Histologically, this is a focal, segmental, crescentic, necrotizing glomerulonephritis that has few to no immune complexes, or so-called pauci-immune glomerulonephritis. Now, although this is known by its involvement of the sinus, lung, and kidney, there are other prominent sites of disease where this can occur. Ocular involvement occurs in about 56% of these patients, where it can involve any ocular structure and be potentially visually threatening. We can see here some of the more common features, which include scleritis and episcleritis, or orbital disease, which can occur either de novo or through extrusion through the lamina praepatia from adjacent sinus disease. This can result in proptosis, diplopia, or potentially threat to vision by pressure on the optic nerve. Another common site of involvement is the skin, which is effective in 46% of patients. We can see here features of vascular infarcts involving the skin and nail folds, and we can also see on the right evidence of a verrucous lesion appearing on the elbow, which is a common site of involvement, and if biopsied often may reveal acute and chronic inflammation or sometimes granuloma. So we can see that granulomatosis with polyangiitis is very much a multi-system disease, and although associated with the sinus, lung, and kidney, just about any organ site can be affected, which provides reason for why we can see the disease severity that is present and the diversity of clinical manifestations that can occur. This has an influence in our differential diagnosis, which most prominently includes the possibility of infection, neoplasms such as lymphoproliferative diseases, other connective tissue diseases, granulomatous diseases such as sarcoidosis, and when the kidney is affected, other causes of glomerulonephritis. In these instances, differentiation from GPA is essential as the treatment is different in many instances. So the goals of the diagnostic evaluation are really focused on looking for objective evidence of disease that is affecting a target organ site. We are looking to assess the severity of that disease if a target organ is affected, because potentially organ or life-threatening disease can occasionally lack symptoms. We are looking for evidence that might point away from the diagnosis of GPA, and ultimately to identify a means by which we can definitively prove the diagnosis. We do this similar to how we approach any other problem in medicine or rheumatology, by looking at the clues that we are given from history, physical exam, radiographs, and laboratories. Symptoms play an important role in terms of their presence and duration. There are certain organ sites by which physical examination plays one of the major roles in detecting disease activity, such as examination of the nasal membranes, the eye, skin, joints, and nerve. Chest imaging is important even in the absence of symptoms, as up to 1/3 of patients who have active pulmonary disease may be completely asymptomatic and have a normal examination by auscultation. In terms of laboratories, our most important tests are in many ways our most basic, looking at evidence of the patient's renal function, complete blood counts, acute phase reactants such as erythrocyte sedimentation rate or C-reactive protein. And as mentioned, urinalysis plays a very important role in the assessment of Wegener's GPA, as if there is blood, we want to perform microscopy on a fresh urine sediment to look for casts. And then there is the issue about the serology of ANCA. So that brings us then back to our case question about which of the following investigations we would recommend be performed to evaluate for a possible diagnosis of GPA. And as we look at this list, really the 4 top choices are important. We would want to check a serum creatinine to know the patient's renal function. We would want to know their urinalysis to look if there was evidence for protein or blood. Computed tomography of the chest is important to look for asymptomatic pulmonary disease, and antineutrophil cytoplasmic antibodies play a role in suggesting this important diagnosis. In the patient with this clinical presentation, antinuclear antibodies would not be a diagnostic test that we would consider in looking for the possibility of GPA Wegener's. So as we pursue this diagnostic evaluation, what is found is that the laboratories reveal a white blood cell count of 14.2, hemoglobin of 9.1, and platelets of 502,000. The creatinine is 1.8 and was known to be 1.0 at his physical examination 1 year ago. The sedimentation rate is elevated at 65. Urinalysis reveals 1+ protein with 20 to 25 red blood cells, and there's the presence of red blood cell casts. And the ANCA returns back positive in a cytoplasmic or ANCA pattern. In continuing the diagnostic evaluation, computed tomography of the sinus reveals mucosal thickening involving the ethmoid, sphenoid, and maxillary sinus. Chest CT reveals 3 nodules being present. The largest is 2.2 centimeters, seen here. So our second question says that this patient has a positive ANCA. Which of the following is true about this test? And once again, you would choose all applicable options. A positive ANCA is always diagnostic of GPA. B, ANCA is directly indicative of active disease. C, a positive ANCA should be confirmed by proteinase 3 testing. D, proteinase 3 is the most common antigen specificity in GPA. And E, up to 20% of patients with GPA can be ANCA negative. So this question really refers to the diagnostic role of antineutrophil cytoplasmic antibodies, or ANCA. These autoantibodies were first described in the 1980s and were determined to have an association with GPA and small vessel vasculitis such as MPA towards the late 1980s and early 1990s. Using indirect immunofluorescence, 2 immunofluorescent patterns can be seen. A cytoplasmic staining pattern, which corresponds to the antigen proteinase 3, a 29 kD serine protease found in the eosinophilic granules of neutrophils, and perinuclear staining ANCA, or p-ANCA, which in patients with GPA or NPA target the neutrophil enzyme myeloperoxidase, or MPO. There are 2 commercial methodologies by which ANCA can be tested. Indirect immunofluorescence, which provides us with our C or p-ANCA staining pattern, as well as target antigen-specific ELISA testing that detects antibodies specific against proteinase 3 and myeloperoxidase. This is important to recognize because what can be positive by one testing methodology may not always be positive by the other, and this has importance in terms of our diagnostic interpretation. In the case of ANCA, our vasculitic diseases such as GPA Wegener's, microscopic polyangiitis, or EGPA Churg-Strauss syndrome, we would expect to see a concordance between a positive ANCA and a positive anti-PR3. However, there have been important case reports of associations, including infections such as endocarditis and tuberculosis, where patients may have a positive ANCA but have a negative anti-PR3. This becomes even more important in the case of p-ANCA, which once again are vasculitic diseases. We would expect to see a match between a positive p-ANCA and a positive anti-MPO. But there are a broad range of known p-ANCA associated diseases in which a negative MPO will be seen, and this includes in the setting of inflammatory bowel disease, other autoimmune diseases, infections, and potentially medications. So for this reason, a positive ANCA that is done by immunofluorescence should be confirmed by doing antigen-specific proteinase 3 and myeloperoxidase ELISA testing in order to know how to optimally interpret these results. In the case of GPA, the strongest antigen association is with proteinase 3 ANCA, in which about 75 to 90% of patients may be positive. About 5 to 20% of patients may be positive for myeloperoxidase p-ANCA. And what's also important to recognize is up to 20% of these patients may be ANCA negative, such that having a negative ANCA does not rule out the possibility of GPA. However, because of this high degree of association, the question has been raised as to whether a positive ANCA can be used to diagnose GPA in place of invasive tissue biopsies. The answer to this is that it depends upon the likelihood of the disease based on the clinical scenario, and that it is influenced by the fact that GPA is uncommon and also because of the toxicities of treatments that we would talk about using in this setting. So in the case of a patient who has very characteristic sinus, lung, and renal disease, particularly when bronchoalveolar lavage has been performed to rule out pulmonary infection, a positive ANCA would have a predictive value of about 90%, making it comparable to what we would see with biopsies. However, in other more isolated settings where patients, say, may have sinus and lung disease, the predictive value of ANCA goes down significantly to about 30 to 60% because there remains a high potential of infection and or neoplasm. This tells us that a positive ANCA has a poor predictive value in low prevalence population, and diagnosis by biopsy remains necessary in many instances. This raises a question about what we would expect to see on diagnostic biopsies, and the histologic features in a clinically compatible setting would include that of necrosis, granulomatous inflammation, vasculitis, and the performance of special stains and cultures being negative for microorganisms, as similar findings can be seen in the setting of infection. Now, unfortunately, not all biopsies are diagnostic. The changes may be patchy, and the likelihood of a positive yield is associated with the amount of tissue that's obtained. Tissues from the ear, nose, and throat region are relatively less invasive, but have a relatively low rate also of diagnostic positivity of 21% or less. The highest yield comes from biopsy of radiographically abnormal pulmonary parenchyma, and studies from open lung biopsies have revealed yields of upwards of 91%. Transbronchial biopsies are far less invasive, but have a very low positive yield of 7% because of the small amount of tissue that can be obtained. We discussed earlier about the findings on renal biopsy of post-immune glomerulonephritis, and skin biopsies, while being the least invasive of all, are usually insufficient evidence from which to target the diagnosis because cutaneous vasculitis can be seen in many settings, including infection. Now, the other way that ANCA has raised clinical interest is whether it is a reliable measure of disease activity. It has been found through serial studies that ANCA is not a static test, and in an individual person, the ANCA level will often vary over time. In early large series, patients who had active as compared to inactive disease were often found to be more frequently ANCA positive and have higher titers of ANCA. And this led to the question as to whether ANCA can be used to predict relapse and guide treatment. Unfortunately, this has not been found to be the case. In two series from the 90s and early 2000s from the NIH in Netherlands, strikingly similar findings were found in which 43% of patients who had a fourfold rise in titer did not go on to relapse. The largest study to date was performed in conjunction with the Wegener's Granulomatosis etanercept trial and followed 156 patients prospectively over time. In regards to this specific question, increases in ANCA level were not associated with a relapse, and 43% of those relapsed within 1 year of an increase in ANCA level, therefore demonstrating that this was not necessarily a reliable finding over time, indicating the presence of an imminent relapse. So unfortunately, ANCA titers do not correlate well with disease activity and should not be used alone to guide our immunosuppressive therapeutic decisions. So as we look then at our case question for this patient with a positive C ANCA, what we can see is that a positive C ANCA should be confirmed by proteinase 3 testing. Proteinase 3 is the most common antigen specificity in GPA, and up to 20% of patients with GPA can be ANCA negative. Unfortunately, a positive ANCA is not diagnostic of GPA in all instances, and it is also not directly indicative of active disease. So in turning to our final question, our patient has evidence of target organ disease involving the sinonasal tract with abnormal mucosa by direct visualization and CT thickening. He has cutaneous disease with these elbow lesions, pulmonary involvement with 3 nodular lesions without respiratory compromise, but he does have active kidney disease with an active urine sediment and a rise in creatinine from 1 to 1.8. The proteinase 3 C ANCA also comes back strongly positive. So in the setting of a compatible clinical picture involving a spectrum of characteristic organ sites, the positive predictive value of the proteinase 3 ANCA would be greater than 90%. And based on this, you agree that there is compelling evidence to support a diagnosis of GPA Wegener's. So in addition to glucocorticoids, which of the following initial treatment approaches is an option for your patient? And once again, you will choose all applicable options. A, daily cyclophosphamide, B, intermittent intravenous cyclophosphamide, C, methotrexate, D, azathioprine, or E, Rituximab. So when we talk about the treatment of GPA, it's important to focus on what are the goals that we are seeking to achieve. We do recognize that GPA remains a potentially life-threatening disease, and protection of patient survival remains our foremost concern. However, because of the effectiveness of our current treatment options, we are able to broaden our goals to include that of inducing remission of active disease, where remission would be defined as the absence of disease activity. We are seeking to avoid disease relapse, whereby relapse would be a return of that disease activity after remission. And as we have gained appreciation of over time, we are seeking to minimize therapeutic toxicity. Well, it wasn't all that long ago that this was a very bad illness to have. Back in the 1950s, there was no form of available treatment, and the median survival time for patients with GPA was about 5 months, with mortality occurring from pulmonary or renal failure. With the introduction of glucocorticoids, although these prolonged survival in some instances, the survival time remained just over 1 year. However, the outcome for these patients dramatically changed with the introduction of daily cyclophosphamide and prednisone by Fauci and Wolf at the NIH in the 1970s. In their original series, remission was seen in 12 of 14 patients, and in the longer-term series by Dr. Hoffman in 1992, 75% of these patients were seen to have a complete remission, 90% had improvement, and most significantly was an 80% survival rate was seen. In current day, we think about treatment in terms of different phases. Induction, where active disease is put into remission, followed by remission maintenance. This is further stratified based upon the degree of disease severity, whereby severe disease is initially treated with cyclophosphamide or rituximab for about 3 to 6 months in terms of cyclophosphamide, followed by maintenance with methotrexate, azathioprine, or potentially mycophenolate mofetil. And non-severe disease can be treated with methotrexate and glucocorticoids in patients who do not have contraindications. The factors that we take into consideration in determining which of these treatment options to use include the level of disease severity, whether this is initial disease or a disease relapse, and in terms of our maintenance choices, medication contraindications, and the patient's past treatment history. When we think about the spectrum of GPA, we recognize that patients can have anywhere from mild to severe disease, whereby severe disease would be characterized by features such as alveolar hemorrhage, glomerulonephritis, involvement of the central nervous system, pericarditis, or other organ or life-threatening disease. And in this setting, the treatment options would be that of cyclophosphamide versus rituximab. Cyclophosphamide is a nitromustard derivative synthesized in 1958. It's an alkylating agent that has been known to have potent antineoplastic and immunosuppressive properties. One of the main limitations of cyclophosphamide has been its side effects, which include not only acute toxicities such as infection, bone marrow suppression, and cystitis, but also long-term complications, which can include infertility in both men and women, myelodysplasia leading to lymphoma or leukemia, and the potential for bladder cancer. One of the questions that had often arisen regarding the use of cyclophosphamide are whether there are relative benefits between the use of daily administration versus that of intermittent intravenous administration. This slide demonstrates a study conducted by the European Vasculitis Study Group that compared these two regimens. Of note to look at in this study design was that the intravenous regimen that was used consisted of 15 milligrams per kilogram every 2 weeks for 3 doses and every 3 weeks thereafter, making it different from the monthly intravenous cyclophosphamide regimen that many people are more familiar with in terms of the treatment of lupus nephritis. The other aspect of this study design was the use of a consolidation phase by which patients received an additional 3 months of cyclophosphamide after achieving remission. In these 149 patients, the time to remission was equal between daily and intermittent cyclophosphamide at a median of 3 months, which was comparable to what has been seen in prior studies. In terms of long-term relapse, longer-term studies have demonstrated a higher rate of relapse in those who received intravenous as compared to daily cyclophosphamide. Those who received intermittent cyclophosphamide had a lower total cyclophosphamide dose, although this was comparable at 3 months prior to the consolidation phase. And there was also a higher rate of leukopenia in those who received daily cyclophosphamide. This may have been influenced by the frequency of CBC monitoring, which was increased over time. So what this study told us, in those who do favor intermittent cyclophosphamide, when given in this regimen, it is effective, but it is not superior to daily cyclophosphamide, and it may be associated with a higher relapse rate. For those who favor daily cyclophosphamide, this remains a very valid option. The goal should be to aim for 3 to 4 months of treatment with CBC monitoring every 1 to 2 weeks for as long as they are receiving cyclophosphamide treatment in order to detect and prevent leukopenia. The most recent regimen that has been used involves the use of Rituximab, which is a chimeric monoclonal antibody directed against the CD20 antigen present on the surface of normal and malignant B cells. Upon Rituximab binding to CD20, there is B cell depletion that occurs. This agent is currently approved for B-cell lymphoma, rheumatoid arthritis, CLL, and as of 2011, GPA and MPA. It does have side effect profile, which includes infusion reactions, rare instances of progressive multifocal leukoencephalopathy or PML, hepatitis B reactivation and other infections, and mucocutaneous reactions. Rituximab has been studied in 2 randomized trials. In the study that led to FDA approval, called the RAVE trial, cyclophosphamide transitioning to azathioprine was compared to Rituximab given according to the lymphoma regimen of 375 milligrams per meter square per week for 4 weeks, combined with glucocorticoids. This study had important significant exclusions, which included a creatinine of greater than 4 and mechanical ventilation. In these 197 patients, in examining the primary endpoint, which was being in remission and off prednisone at 6 months, Rituximab was as effective as cyclophosphamide. In looking at a sub-study as far as those who were enrolled at the time of relapse, there was suggestion that Rituximab may be more effective than cyclophosphamide. Overall, there was a comparable rate of adverse events. At this 6-month time point, there was evidence of relapses beginning to emerge in both arms, and there was a low rate of mortality. So this study provided evidence that for remission induction, Rituximab is as effective as cyclophosphamide, and this formed the basis for FDA approval in 2011. The other randomized trial that was performed by the European Vasculitis Study Group compared Rituximab, again, to cyclophosphamide. Most significantly was that all patients did receive 2 pulses of cyclophosphamide and then underwent the randomization to either continue cyclophosphamide or be treated with Rituximab. This study was designed as a superiority trial in which they sought to examine whether Rituximab was more effective than cyclophosphamide. In this study of 44 patients, Rituximab, although it appeared to be as effective, did not meet the primary endpoint of being superior as compared to cyclophosphamide. Once again, there was a comparable rate of adverse events. There was a higher mortality rate seen in this study, which was likely influenced by the older median age of enrollment of 68, and also that 20% of these patients were on dialysis at the time of enrollment, both of which have been found to be poor outcome factors in this disease. So this study provided evidence, again, that rituximab was effective, but it was not superior to cyclophosphamide. As we currently ponder the use of rituximab, we recognize that there remain important ongoing questions. What is the relapse rate with rituximab? What do we do about our maintenance therapies after rituximab has been received, as far as whether this should be further rituximab or conventional agents? How often should rituximab be given? Whether there are organ-specific effects? What is the role in either non-severe or more fulminant disease, which were not the focus of either of the randomized trials? The issue of long-term concerns with rituximab, and ultimately understanding the mechanism of action of rituximab and whether it is independent of ANCA. These important questions will be answered from ongoing and future studies, but until we have those answers, these do factor into our current patient counseling. So in coming back to our question about, in addition to glucocorticoids, which of these medications would be options, as we had discussed, this is a patient that does have severe disease, as evidenced by active glomerulonephritis with a rise in creatinine. This would make the three treatment options either daily cyclophosphamide, intermittent intravenous cyclophosphamide, or rituximab. Neither methotrexate or azathioprine should be considered in this setting. So in summary, when we talk about small vessel vasculitis, it's important to recognize that although our case discussions today focused on GPA, this is by no means the only disease in which we can see small vessel vasculitis occurring. This also can include microscopic polyangiitis, EGPA Churg-Strauss syndrome, Henoch-Schönlein-Purpur, which is predominantly a disease of children but can also occur in adults, cryoglobulonemic vasculitis, cutaneous vasculitis, or secondary forms of vasculitis. As we focus on diagnosis, it's important to look for objective evidence of disease that is affecting target organs. And in particular, some of our most important tests include a urinalysis and chest imaging, as disease may lack symptoms in these locations. In terms of the role of ANCA, a positive ANCA is valuable but is not absolutely diagnostic, and a negative ANCA does not rule out a diagnosis. A positive C-ANCA or P-ANCA should be confirmed by doing proteinase 3 and myeloperoxidase testing, and it should be recognized that ANCA is unfortunately not reliable as a disease activity marker at the level of the individual patient. As we consider initial treatment, we want to confirm the presence of active disease. We stratify our initial treatment decisions based upon disease severity. And as we look at patients as they go over time, we examine their relapse and past treatment history and medication contraindications. Thank you for attending today's session. We hope this will help in your management and approach to small vessel vasculitic disease. Thank you.
Carol, that was really fantastic. I think you've outlined so many of the important points in approaching a patient with vasculitis. One, is the diagnosis secure? Two, what is the activity of the disease, meaning what is going on in each organ system at the time of the encounter? Three, how much damage is present? How much of this is reversible and irreversible? And four, really knowing the data on therapy. This case is very interesting. I first thought it was going to be a case of limited disease, but then saw the RBC CAS in the urine and the azotemia and knew that this is going to be more serious and warranting either cyclophosphamide or rituximab. I probably would opt for rituximab in this patient. Just based on experience and long-term toxicity, but either regimen would be good. Please come back to our website. There are many other programs on vasculitis that are easy to search. Please come to our satellite symposium next spring here at the Cleveland Clinic, organized by Dr. Langford on large vessel vasculitis and Churg-Strauss disease, and come back to our website time and time again.